No, reading out loud to himself and having her not bother to show up. So you talk.
Good evening, Kat. This is week 4, the last week of the mod. We need to do a couple of things. You're behind on 2 discussions, so you need to catch up on those. All your other work is done. This week we'll have discussion. We'll do an in-class on Wednesday, your final assessment, and then the usual career integration thing here. This week's discussion is about the lymphatic system. So you'll be discussing common disorders of that system so that um, so that you can understand this important system in the body a little bit better. Um, let's take a quick look at your grades. And there are the discussions from the last 2 weeks that you haven't done. But everything else is caught up, and that's really good. So we're going to go back and we're just going to talk today about a couple of other things. And this particular week, we've got a couple of things here, and we will look at a couple of a couple of other chapters in the book in terms of readings and tools. We're doing chapters 20 through 22. So I'm going to bring up chapter 20. So here we are in chapter 20, which is about the urinary system. So we'll go on down here. It really works with the production, storage, and excretion of urine. These processes maintain homeostasis and remove toxins from the body. It cleanses the blood of waste. It regulates water, salts, acids, and there's a function in it has a function in regulating blood pressure as well. It's there are 2 kidneys, 2 ureters, the bladder, and the urethra. The ureters connect the kidneys to the bladder, and the urethra connects to the exit port. In the female, it's in the vulva area, and in the male, of course, it's through the penis. One of its most important functions is to filtrate blood, filter the blood and remove products. There are about 1 million nephrons in each kidney, and the kidney is about fist size, which where they actually do their thing. They filter, reabsorb, and secrete. Reabsorb water, reabsorb certain nutrients, and then secrete the urine. Other functions, they secrete renin to raise blood pressure, and erythropoietin to stimulate red blood cell production, and it also activates vitamin D. We often do blood tests and urinalyses. You've taken urinalysis, so you're familiar with those, and you've taken hematology, so you know that we can, after we draw blood, we can examine the markers that the kidney secretes to tell us about the kidney function. We do the tests that we can do on the urinalysis and on the urine itself, and on blood tests and others are, we can look at culture. We can culture these things to see what antibiotics we might need for kidney and bladder infections. We've got ultrasound and CTs for examining for structural abnormalities. Cystoscopy is something that happens when um, a, um, a sensing device is pushed through the urethra into the bladder. And we can also, if we're looking at the bladder and seeing that there are some abnormalities, we can and lesions, which are areas that are not right, we can simply do a biopsy. The kidneys are one of the more important. Well, there's no such thing as an unimportant organ in the body. Everything is there for a purpose, but the most of our waste and toxins will go out through the kidney. They are carried by the blood into the kidneys, filtered out, and then passed into the urine. This is why uh, most drug tests are urine-based, because almost all those metabolites that we can measure, and sometimes the raw drug, will come out through the kidney and then go into the ureter and into the bladder and out the urethra. They're critical organs for um, maintenance of, we said homeostasis of the blood, but the chemical composition of the blood, meaning um, they help regulate the amount of protein, the amount of electrolytes, sodium and potassium and so forth, um, and, um, and help remove, as I said, toxins. They're oval, sort of. There's a reason that the little red beans called kidney beans are called that, because that's exactly the shape of the kidney. Um, so the renal artery enters on one side, and then the filtered blood exits the kidney back into the circulatory system via the renal veins. So much the same way that we have veins and arteries for blood circulation, um, the um, the blood goes into the kidney through an artery and then comes out through a vein. Um, Urine contains water, um, uh, lots of waste products, hormones, ions, um, and many substances. Drug metabolites are quite common. Uh, the kidney is surrounded, has a renal capsule around it, which is connective tissue. And below this, the renal cortex contains below that capsule, the cortex contains nephrons, and the inner renal medulla consists of renal pyramids, cone-shaped structures called renal pyramids that are separated by the renal columns. So here is a really good graphic. So we have the outer part of the kidney, the shape here. So here comes in, this is a vein that exits the artery that feeds blood into the kidney, comes in through this little indentation here. And so we have this renal pyramid, cone-shaped thing, and then the columns in between. They're roughly columnar in shape. So we have the cortex is the area here between where the columns and the pyramids start, and the outer capsule. Um, and then we have the various other minor structures in here. So and here's the ureter coming out. So this is the gross anatomy of the kidney. The nephrons are the working units of the kidney, and each kidney contains somewhere between 1 and 2 million of these things. Each of which consists of what they call a renal corpuscle and a renal tubule. The nephron begins as a double-walled globe-shaped capsule called Bowman's, and a renal corpuscle is composed of a cluster of capillaries called the glomerulus. So let's see, we don't have any of the micro. The glomerular capsule receives the fluid filtered at the glomerulus. Then the renal tubule leads away from the capsule and coils in several ways. In terms of, we have a proximal convoluted tubule. The next section is a loop called the loop of Henle. It's the descending limb of Henle, which bends into a U-shaped loop of Henle. This named after the character who really looked first and discovered and described these microscopic structures. From the loop, the tubule ascends as the ascending loop to another tubule, distal convoluted tubule. So we've got the proximal, this is at the front end, and the distal is at the back end. So the fluid moves through this tubule from the proximal through the whole section of the glomerulus, which starts at the proximal tubule, runs through the loop of Henle, and then goes to the distal tubule, which then merges into a collecting tubule. The vast number of these tubules then merge to form larger ducts that continue through the renal pyramids and then empty into the renal pelvis. So let's go back up here. The renal pelvis is this area just before the ureter branches off. So everything begins to collect along this route. Material moves in comes in through the blood, is split up into the various capillaries, and then circulates through all of those structures in the glomerulus. So here is another complex picture of a nephron. Okay, so we have this structure. We talked about the loop of Henle. This is the loop of Henle. Okay, and this is facing downward toward the center, the medulla, and upside is facing toward the cortex. It's in the cortex. So we have the blood coming in to the capsule, the glomerular capsule, and into the glomerulus, and then circulates through and around all of these loops, gradually converting into a vein, venules, and the small vessels. So comes in, moves into the glomerular capsule, and circulates back out of the capsule and into this area that connects up around the proximal convoluted tubule. So then it moves around and connects around into the capsule here. Material goes into the descending limb of the loop of Henle, up the ascending limb, and then circulates up into this area, the distal convoluted tubule. So this structure is this drawing of the structure obviously is quite detailed, but we have the capillaries that circulate around. Ultimately, at the end of the distal convoluted tubule, it goes into the collecting duct. So the urine then flows out of there, out of that collecting duct. And this is just a notation that there are a lot more of these nephrons connected up to this particular duct that then feeds the urine into the minor calyx. So let's go back up here. The minor calyx is just before the pelvis. Okay. So there are lots of minor calyces. Calyces is the plural of calyx. The minor calyces move material into the major calyces, these larger collecting ducts, and then all of that merges smoothly in a normal kidney to the ureter. So the urine flows out of the kidneys via the ureters, and they transport it to the bladder. And there's a mix of peristaltic contractions, just like your gut works, and gravity and just pressure. So the contractions occur at the rate of 1 to 5 to the minute based on the amount of urine. The bladder is positioned here in the pelvic cavity, just behind the pubic bone, and held in place by folds in the peritoneum that we call the peritoneal folds. It is a smooth, it has smooth muscle walls. It will stretch out as it fills, and then it appears deflated when it's empty, and has a full capacity of about a half a liter in an adult. It opens into a ureter, as well as the urethra. The bladder collects urine from each ureter, but there's just the one urethra which leaves. So the term micturition is also urination or voiding, emptying the bladder as it expels urine. Average capacity is, as I said, 500 milliliters. When it reaches somewhere between 2 and 4, you've got receptors in there that sense that it's getting filled and sends a signal to your control centers in your brain that says, "I gotta pee." So we go and do that. As with many connections of tubes to sacs like the stomach or the bladder, there are sphincters, little muscles that will contract and keep you from just dribbling out everything as fast as it comes in. That that external urinary sphincter, which leads to the urethra, must relax. Okay, so in a female, this is how it's going to look. So the kidney, the ureter comes down. This is a cross section. There's connective tissue. There is a muscular layer that allows for the contractions, the sort of like milking a cow, the contractions that push urine in from the kidney into the bladder. There is a little epithelial layer in there This obviously can expand and contract a little bit, but there's various connective tissues.
Sure.
So that goes down into the bladder, which is roughly this shape. This is the actual opening of the ureter, and then there is the urethral opening that allows urine to flow out of the body. The layers of skin and muscle that make up the bladder sac include a muscular layer, some connective tissue, and the connective tissue we call the adventitia, which is the outer layer here. And you can see it has veins and arteries in it. And then there is, between the connective tissue and the interior of the bladder, there's this transitional skin layer of cells, a transitional epithelium. In a male, so in a female, it's shaped a little differently than a male. Let's take a look. In the male, there is a narrower opening because it's going into the penis and not into not into the vulva area. So we have the ureters coming in and the ureter openings. Surrounding in men at the base of the bladder, there is the prostate gland that the opening to the urethra goes through, and then there is a muscle. There's the prostate gland here, this sort of walnut-shaped thing. There is an internal sphincter and an external sphincter. The internal sphincter keeps things from flowing out, and the external sphincter is a muscle that is adjacent to the prostate in a male. The urethra is a thin tube that is quite a bit shorter in women than in men, which is why women tend to be more prone to bladder infections than men. So to reiterate, functions of the kidney: filtration and reabsorption and secretion through the various tubules, the tubes in the nephrons. So 1 to 2 liters of urine are generally produced every day, but that's based on how much fluid is consumed. And we can modify this, and the elderly often do, by simply refusing to drink. This is a bad strategy because dehydration can set in. There is a reason that we put out this much urine and that we are encouraged to drink at least that much water every single day. And that doesn't mean soda pop and other things. It means water. But we need to be pumping this out. Part of it is a cleaning operation and getting things out of the body and getting them out on a regular basis. So these are a number of things. Water is filtered out because we are supposed to have only about 5 liters of blood, and this is all connected through. The blood goes through here, so this helps control the blood pressure by monitoring and controlling the amount of fluid in our circulatory system. So the water is filtered: sodium, sugar, waste products, toxins, and other things. Urea, phenol's another compound that we take out that's not a good one to have. So if we look carefully at the glomerulus, this knot of vessels, blood comes in through what we call the afferent arteriole. In other words, afferent means basically the entrance. The glomerulus is this tangle of vessels inside Bowman's capsule, which is just the thing that holds it. So what happens is here we filter things out of the blood, and it goes into the renal tubule first, where we reabsorb a lot of water and pick up further secretion of unwanted things, toxins, excess electrolytes, etc., from the blood, and then it flows. Excuse me. Then it flows on. So so what happens is the blood goes through the capillaries, and the capillary walls in the capsule will filter water and some other dissolved materials, proteins and other things, to form a glomerular filtrate. Then this travels to the Bowman's capsule, where things like red blood cells and other things are trapped. And then it passes to the tubules. Most of the fluid that is filtered in the glomeruli is reabsorbed from the renal tubule back into the bloodstream. That's what this picture is showing: the renal tubule, water, and other substances going back into the bloodstream. This occurs mostly in the proximal convoluted tubule, and it preserves water, ions, and nutrients that may have been filtered out, that we still want, but it's physically filtering things and choosing specifics to filter out is not easy. So tubular reabsorption, occurs, but we leave waste products behind in that filtrate, and that will ultimately become part of the urine. This process helps control blood pH, which is the acidity. And though 45 gallons of filtrate are produced in the kidneys every single day, only 1% leaves the kidneys as urine. The rest of it's reabsorbed. Tubular secretion is a way to remove wastes from the blood, meaning those not filtered in the glomeruli. Some of these move through the capillary walls into the nephron, which occurs distal or beyond the convoluted tubule. Tubular secretion helps to regulate the acidity in the blood, and if there's too much acid, the acid entities will move into the urine to reduce that. So blood going into the renal vein is pretty cleansed, and then it moves through the inferior and superior, through the inferior vena cava back to the heart. As the collecting tubules converge, much of the remaining water escapes from the urine to concentrate it further, and of course to maintain body water. So it's continuously produced. We've got two sphincters as muscular valves to prevent it from leaking out of the bladder, the external and internal sphincters. Um, the internal sphincter is at the neck of the urinary bladder where it joins the urethra, and the external is made out of some skeletal muscle that forms the floor of the pelvic cavity. Both internal and external sphincters have to relax for urine to be pushed into the urethra to exit the body. In adults, urination does not occur until there is a conscious relaxation of the external sphincter. And this is something children have a hard time consciously controlling until they are 2 to 3 years old, which is why we keep them in diapers. But the issue is that we also have disorders where that sphincter control is not good. We call that incontinence, urinary incontinence. Hormones. The water, the reabsorption of water is partly controlled by a hormone we talked about last week, antidiuretic hormone, which is reduced. The amount of ADH which is produced is reduced when blood volume increases and water intake increases blood volume and decreases the concentration that occurs across membranes. Aldosterone from the adrenals, we talked about that. It's controlled by blood pressure and the volume of fluid inside the nephrons. The enzyme renin, part of the renin-angiotensin system that controls blood pressure. Renin is produced due to a decrease in blood pressure and the amount of volume in the nephrons. And in the bloodstream, it interacts with angiotensinogen, which is used. Angiotensinogen is an enzyme that catalyzes the production of angiotensin. Renin, or it's a precursor to angiotensin. Renin removes a piece of it to produce angiotensin 1, and then there's another enzyme which converts to the active form called angiotensin 2, and which stimulates the production of aldosterone. And aldosterone helps stimulate renal or sodium resorption. And then we already mentioned that the kidneys secrete erythropoietin to stimulate RBC formation, red blood cell. So disorders, a whole list of these things: hydronephrosis, pyelonephrosis, renal calculi, kidney stones, glomerulonephritis, renal failure, nephrotic syndrome, or nephrosis, polycystic kidney disease, and diabetic neuropathy, nephropathy, and neurogenic bladder. Hydronephrosis is a distension of the structures, the pelvic and calci, the tubes of the kidney by urine when a ureter is obstructed by something. It can be obstructed by a tumor, a kidney stone, or in men, inflammation and swelling of the prostate gland, or edema, pain, inability to urinate, loss of kidney function, infection is actually quite painful. Hydronephrosis treatments can be surgery or antibiotics if they're caused by infection. Treatments, as it says, are based on underlying causes and duration. And it may be necessary to insert a tube called a nephrostomy. Um, this is the typical ostomy type tube that connects up to some portion of the body, such as a colostomy or one of those. So it's a lot like that. Pyelonephritis is an inflammation often caused by infection, and it occurs in um, after bladder infection in older women and during pregnancy, and it is something to worry about in diabetics. Pyelonephritis is another inflammatory disease that is really causes a lot of issues. Pelvis, renal pelvis. Don't confuse the pelvis with the renal pelvis. The renal pelvis is part of the structure of the kidney. Produces abscesses, fever, chills, nausea, etc. All of this list of nasties. And we use a lot of antibiotics, specifically the fluoroquinolones and the cephalosporins. We also want people to drink a lot more fluids, take to bed rest, and potentially surgery to deal with the issue. Kidney stones or renal calculi are made of calcium salts and other things. They're more common in males between 30 and 50. Risk factors of these things: chronic urinary tract infections. Dehydration is a major issue because then when you're dehydrated, things that normally stay in solution will actually crystallize out. Immobility, bed rest, hyperparathyroidism, gout, bone disease, and others. Renal calculi, hematuria, and the symptoms are for renal calculi are basically severe flank pain, pain in your back and around the area in the lower abdomen. Analgesics for the pain, increased fluid uptake to try and dissolve it. Um, the We can strain urine samples to pick up on pieces of these things to identify the makeup. Sometimes surgery is necessary, and the process of lithotripsy, which basically litho is stone, tripsy means to break apart. And so what we do is we use ultrasound and send a pulsed signal into the area of the pain with the idea that we'll bust it up into small enough pieces to where it's not a problem with them sending them off or getting rid of them. Um, Glomerulonephritis is an inflammation of the glomeruli, usually related to a strep infection, most common in boys, young boys, 3 to 7 year olds, but the chronic form is progressive and may cause irreversible kidney damage. Acute symptoms include protein in the urine, edema, decreased urine volume, hypertension, raised blood pressure, and flank or back pain. Chronic symptoms include hypertension, blood in the urine, sugars in the urine, protein in the urine, edema, meaning we're not we're not getting didn't it doesn't mean it means that we're not getting rid of the water, so it's building up and it's swelling up in the tissues, and we can even have urea crystals appearing in the skin. Treatments: well, we want to lower blood pressure. um, we we want to lower blood pressure. We want to give diuretics, which is another means of doing that. Antibiotics, if that's indicated. and some dietary restrictions to reduce the amount of material that can cause these things to happen, to reduce that, along with increased fluid intake. To reduce excess protein if we have proteinuria, we have ACE inhibitors, the angiotensin converting enzyme inhibitors. Some patients, unfortunately, end up needing dialysis or transplant. Renal failure is a disease. It can be due to obstruction or poor circulation or some other kidney disease. If it isn't treated, it might progress to increased urine in the blood and death within hours or days. We have a number of symptoms here, and it's something that is not necessarily easy to diagnose, but that's what he thinks is supposed, or that's what we think is supposed to happen. Treatments for renal failure: monitoring of everything, evaluate for dialysis, control fluid intake and output, use a high carb, low protein diet, control our potassium and sodium intake, and then we have lots of medications. Chronic renal failure is results from gradual tissue destruction and the loss of function. If we are, we can have all sorts of things. If we're not filtering potassium, the high potassium ion concentrations can cause the heart to fibrillate, and that can lead to death. We've got chronic renal failure is a nasty disease. Symptoms list here: weakness, tiredness, hypertension, edema, arrhythmias, etc. All these things can be symptoms of renal failure. Treatments: look at the potential for dialysis and/or transplantation. Look at diet and nutritional changes. Regulate fluid intake. This sounds familiar, doesn't it? And then a series of medications to try and help reduce the amount of fluid buildup. And vitamin D. Nephrotic syndrome is a protein spilling kidney. It occurs secondary to many other kinds of disorders, and it's because of somehow developing an increased permeability to the glomeruli. Causes: glomerulonephritis, drugs, toxins, a lot of different things. This important system is affected by a lot. Symptoms can include all of this list: protein in the urine, reduced albumin, hypertension, blood in the urine, plasma lipid levels going up, ketones in the urine, etc. Lots of things. New treatments include, again, we look at dietary protein control, getting sodium intake down, which means changing diet a lot of times because we have a very high sodium diet in this country. Use of diuretics, angiotensin converting enzyme inhibitors, corticosteroids, and then very careful monitoring of urine output. A polycystic kidney disease, it's an inherited disease. We look at cysts. These look like grape-like clusters, fluid-filled in both kidneys, swelling of the kidney, and you can actually feel it on the outside because it's very large. Pain, hypertension, blood in the urine, etc. Treatments: dialysis, transplant, and management of UTIs and of hypertension. So here's an example of a polycystic kidney. These cysts form all through. It expands the kidney, and these cavities are fluid filled. Diabetic nephropathy, which is something that all type 1 diabetics will develop. It involves glomerulosclerosis, which is a condition in which the filtration rate decreases. So we got high blood pressure, urinary retention, protein in the urine, UTIs, and we discussed pyelonephritis already. Diabetic nephropathy, it's an irreversible condition, and treatment is always individualized, meaning we really don't have something that we can say, here, throw this at it. So neurogenic bladder is a bladder control issue, including difficulty emptying or incontinence. It is linked to nerve damage that can result from stroke, trauma, surgery, disease, tumors, herniated lumbar discs. So neurogenic bladder symptoms include hesitancy to urinate, retention, a constant sensation of fullness, uncontrolled contractions of the bladder and the vessels, decreased volume of the stream of urine, and an inability to void without applying pressure to the suprapubic, in other words, above the pubis area. Neurogenic bladder treatments. We have to prevent UTIs and try to find a way to restore function. Catheterization is a part of that. Certain medications, surgery, and then external collection devices. Medications that we use are diuretics, antibiotics, urinary analgesics, and anticholinergics that we use to treat these diseases. So we're going to stop here on this chapter, and I'll be back later with other. So they were very closely intertwined as far as interests and careers, and this is her best friend, and he's 30 and he's gone. So anyway, and I know that was in Chicago, and I don't know what the differentials are from one city to the next. And the biggest problem is we don't have testing here. Well, except